Hello everyone, this is Dr. Deepika from Panacea Spine Pain Ortho and Sleep Center. So we have already seen the 𝗣𝗡𝗡𝗣 approach of the transforaminal epidural injection. So today we are going to talk about subpedicular approach or safe triangle approach or supraneural approach. All these are the same kind of procedure. It is just different names. Safe triangle approach is just a nomenclature. It is not a safe triangle or it is not a safe kind of approach. It is just a misnomer. It is very near to the nerve and you might hit the nerve. Very high chances of it will be there. So it is not a safe triangle. It is just a misnomer. Okay. So mainly what we are going to do is we are going to approach the epidural space by the just below the pedicle. So the pedicle will be there at 6 o'clock position. We will be approaching and we will enter into the epidural space and we will give the injection to relieve the pain of the patient. So first let me start off with the anatomy and then we will proceed to the indications, contraindications, then complications, and then we will proceed to the procedure and we will see how it is done. So let's start with the anatomy. So always as a pain physician or anyone who is approaching the spine, you should be very well versed in spinal anatomy. So let me explain on this model the anatomy and I will show you even in the lateral how it will look so that you will be able to appreciate in the fluoroanatomy also. So basically this is the vertebral bodies. Okay, so vertebral bodies, this is the anterior elements and this is the posterior elements. So what we are going to do, the procedure in that we are entering into the foraminal anatomy. So the anteriorly there is the vertebral bodies, the upper vertebral body, lower vertebral body is there and the disc is there. Posteriorly the lamina is there and the facet, that is the IAP and SAP. This will form the posterior border. Medially there is the dural sleeve and laterally there will be the fascia and the muscle, that is the psoas muscle will be there. So this is the anatomy of the foramen and the nerve will come out of there and then go anteriorly like that. So when we are going, this is the subpedicular, that is just this is the pedicle, this is the pedicle and just below the pedicle will be entering. So we don't want to hit the nerve. So the nerve will be more medially present located. So we are going to go little laterally and we'll enter the epidural space and we'll be entering the ventral epidural space. So that will be the drug exactly where the pathology is so that we will get the maximum benefits. That is the advantage of transforaminal approach itself. So in that transforaminal, the triangle which is formed by the lower part of the pedicle and the exiting nerve root. So that is the safe triangle. We will be able to see in the Scotty dog near the neck, chin part. Okay, if you are able to appreciate the Scotty dog, this is the mouth, this is the pedicle. So this is the eye and this is the ear, this is the neck, that is the pars, and somewhere here near the chin will be entering. Let's come to the indications. First of all, any indication for 𝗣𝗡𝗣𝗡𝗣 approach, that is the low in the whole approach as we say, that those indications apply to the subpedicular approach too, because this is also transforaminal only. So other than that, other indications are if we want a selective nerve root block, we are not sure that the whatever we have examined clinically and you have done an MRA, in the MRA maybe there is some ambiguity, you are not sure from exact pain generator from where the pain is coming from, you want to do a nerve block, then you can do this subpedicular approach and you can block that particular nerve with a short acting local anesthetic, very small amount, 0.2 to 0.3, and if the pain is gone, then you are sure that it is coming from that nerve root and you can do your intervention what you want to do or you can do the treatment according. Second is that the patient had previously some surgery done and there is some instrumentation done there and you want to give the pain is very severe, you have exhausted all the other things and you want to do then this approach is very huge disc which is you won't be able to do the transcambens approach because you might enter the disc, then you can go ahead with the subpedicular approach. When you're not able to do the transcambin, then you can do the subpedicular approach. These are the other indications other than for the transcambens approach. Next, let us go for contraindications. So contraindications, if the patient is not willing or not consenting for the procedure, we cannot do the procedure. Another contraindication is if there is some local infection through where the needle will go. So at that site of the procedure, if there is some kind of infection, we will not do the procedure. If the patient has coagulopathy, again it's a contraindication. If the patient is in severe respiratory cardiovascular collapse, then we will not do. Hemodynamic instability is there, we will not do the procedure. Then if the patient is having some kind of myelopathy, then we will not do the procedure. If the patient is having any spinal instability, then try to avoid doing the procedure. They might be a surgical candidate. Then if the patient is having moderate to severe to critical stenosis, central canal stenosis is there, they are having all the symptoms of neurogenic claudication and symptoms of stenosis, then avoid the procedure. It will not help them, they are surgical candidates. Some relative contraindications are like if they are allergic to the medications, such things, then we can still do the procedure. We should just look for the medications, what they are allergic to, and then make sure that we are prepared for any allergic reaction. If they are having very severe allergic reaction, known to already have had allergic reaction to the procedure, to the drugs that we usually use, then better not to do the procedure. Coming to complications, complications can be because of the procedure itself. So inadvertently you have gone intradural or subarachnoid and you have not recognized in the how it looks on the screen, fluoroscopic image, if we didn't realize and we have given the drug, then certain complications can occur like hypotension, postdural puncture headache can happen, motor sensory weakness can happen. So we should always look out for such things. So that is why standard monitors are a must. Always have the emergency drug study with you. Always be prepared with a defibrillator, emergency drugs, monitor. Always have someone to help you, some assistant, someone should be available with you. Don't try to do the procedure by yourself. So anytime if there is some dural puncture, some hypotension is happening, as soon as the complication occurs, immediately we should take action because how fast you act, that can help the patient a lot. So any kind of this thing is required, please have those drugs ready with you. Please load it and keep it with you so that immediately you can act. In the same way, that is the one of the reasons IV is a must. Always have a IV and monitors attached and always have fluid on flow so that anything is required, immediately you can take action. So one of the things is that dural puncture or even intrathecally if it goes, you should be careful. Spinal cord injury can occur, intradiscally it can go and you might inject the drug. The patient will be in lot of pain. Nerve injury, it can happen. They might have loss of sensation. Motor weakness can happen because of nerve injury. So that is also one of the complications. It might cause some kind of infection like discitis, because if you have by mistake you have touched the disc and you have not taken enough care to clean the with betadine and even the needle, take a new needle, all drugs should be used and immediately discarded. It should not be used again and again with the other patients also. So that because you are working around the spinal cord, we should be very very careful. And discitis also, it can happen if you by mistake it goes into the disc because the disc is very near to it, some bulge is there, we might without knowing touch the disc. So when we are giving the 𝗖𝗘𝗘𝗣 dye only, we will realize if it is in the disc, then we will remove it from the disc and then only give the drug. But otherwise also, if one of the complications is discitis, then there might be some epidural hematoma if some vessel in the epidural epidural space gets injured. So then epidural hematoma can occur, epidural abscess can occur later on. Also medullary artery, if spinal cord somewhere is injured or around the spinal cord somewhere injury has happened, medullary artery vein, there can be some bleeding, and that can cause hematoma. Also, you can cause some infection if proper aseptic precautions are not taken. Infection can occur at the site of injection also. And if the patient does not know about his allergic reaction, then whatever drugs we are giving, they might have some allergic reaction. So again, we should be prepared for that. Then they might have vasovagal reaction, and that again, fluid should be, we should apply an IV line. We should start the fluid so that during the procedure the fluid is going on, we are monitoring the vitals, so that even if there is a vasovagal reaction, immediately we can take action. Then a dreaded complication, as I said, going into the spinal cord and giving the drug, which is very rare. Usually spinal cord injury with the transforaminal is rare because you have to be very medial, and if you have gone too oblique and you are going too medial, then it might happen. Very rarely it happens that will go and cause any spinal cord injury, but if it happen, but it can happen. One of the rare complications. Other complications are that we are giving particulate steroid, we might go into some vessel and cause injury there. One of the dreaded complications, that it will cause blockage and anterior spinal syndrome, which can cause quadriplegia. That is one of the dreaded complications, so we should avoid it at all costs. So above L3, or if you are a beginner, always try to avoid particulate steroid, because even if you give the non-particulate steroid, might not cause so many complications. Then anterior spinal syndrome, to avoid above L3, always use non-particulate steroid. Always make sure that you are not intravascular. If you are always aspirate and see before giving anything. Even if you are giving the drug, or before that you are giving dye, whatever it is being injected, before injecting, aspirate and see if there is some CSF coming or some blood coming. Redirect the needle, or even if you are not sure, you can abandon the procedure, but never go ahead with giving the drug if you are not sure that you are in the right place and your needle is in the right position. So before starting the procedure, let me just get you familiar with all the drugs that we are going to use for the procedure. So we are going to first use for our local this 𝗧𝗧𝗪𝗧. This is preservative free 2% 𝗧𝗧𝗪𝗧, which we are going to dilute it to 1%. That is 1 ml of 𝗧𝗧𝗪𝗧 and 1 ml of saline we will take, and we will dilute it and we will give the drug. This is for local, and we will use a 26 gauge long needle for giving the local, because the needle should be as small as possible to avoid too much of pain during the local anesthetic which we are going to infiltrate. So for infiltration, we have to use a smaller needle, as small as possible. 25 to 26 gauges usually acceptable. So we will be using this. We are avoiding giving something with a preservative like 𝗦𝗟𝗘𝗘𝗣, because some patients might have some kind of allergic reaction to it. So to avoid completely such allergic reaction or any complications, we are going to give this 𝗧𝗧𝗪𝗧. It comes in 2% and 50 ml bottle will come. So for each patient we'll use one and we will discard it. We are not going to use it again and again for other patients, to avoid any complication or any contamination, because this does not come with preservative. It should not be used again and again. Same time you can use, because continuously pricking the top, it might again cause some contamination. We don't want that to happen. So one time only we will use it, because it is preservative free. Second, what we'll be using is the dye. So there are two types of dyes. One is non-ionic and one is ionic dye. Ionic dye is not used much nowadays. Only non-ionic dye is used, because it has less allergic reactions to the any patient. So what we are going to use is this iopaque dye, iohexol, and this comes in 350 mg units per ml. So we'll use in the ratio of 30% of the dye, 30 and 70% of saline. We'll dilute it and we'll use it. It's a very small quantity, so even if the patient is allergic, it is a relative contraindication because we'll be using very small amount, very unlikely that they will have any allergic reaction to such a small amount. So we are diluting it to 30 to 70%. So 30% of the dye, 70% of saline. Next, we are going to use this saline. So this is just 100 ml saline which we are going to use. Again, only for one patient, one saline we will use, and we will discard this. We will not use it again and again, so that we don't cause any infection or any complication to the patient. So this we will take in a 10 ml syringe, we will take 10 ml, and this is to wash out any chemical mediators. So inflammatory mediators, because of the disc herniation, the nucleus pulposus is a foreign material to the body. So it will cause immune response, which will cause inflammatory mediators to come to there, and it will cause, usually 10 ml we will take in a 10 ml syringe and we will give it before giving the drug. So next is the drug which we are going to give to the patient, and that can be any local anesthetic. What we usually use is sensory dose, that is very low dosage, so that only the pain reduces. So ropin 0.2%, this is preservative free, or you can also give bupivacaine 0.25%, that is also preservative free. So this along with the steroid is given. So steroid, you can give either particulate or non-particulate. So non-particulate is dexamethasone, 8 mg is there. So you can give this. Usually beginners advisable to start with non-particulate, and then you can go ahead with particulate in the lower, below L3. Okay, particulate it can be methylprednisolone, triamcinolone, or betamethasone. Okay, and your 20, even just 20 mg is more than enough. You don't have to give 40 mg, 80 mg, more than that. It does not make any difference. You can give usually 20 to 40 mg is more than enough to give in the spinal transforaminal. Last but not the least, our Quinkis needle. This is used in spinals, and usually we'll use a smaller gauge needle because we are doing this transforaminal approach. We need, for maneuverability, we need a little larger needle. So this is a 22 gauge needle, that is black one. So you can see a small slot here. So this will be useful in maneuvering, so navigating the needle. So this is the tip, this side is the tip, and this side is the I don't think you'll be able to see that well, but the slot is usually towards the bevel. So we will bend it on the opposite side of the slot very slightly, around 5 to 10 degrees only. Small bend we will give at the upper part, that is 1 centimeter away from the tip. We will bend it slightly, very slightly, for subpedicular. For a transforaminal transcambens approach, slightly more we will bend, but for subpedicular, very slight bend we can do, so that we will be able to maneuver it better. So this is our armamentarium to start the procedure. So let's go ahead and start the procedure.
So now today we are going to talk about transforaminal epidural through safe triangle, otherwise called as subpedicular approach or supraneural approach. We have a case, lumbar PAVD, wherein there is a huge disc. We cannot go through Cambin's approach, so we are doing a subpedicular approach. So if you look at the position of the patient, see there is a small soft pillow under the abdomen. It almost looks like a Wilson frame. So the purpose of this pillow is to kyphose the lumbar spine. Usually any lumbar spine has got some amount of lordosis. We want to obliterate or kyphose the lumbar spine by putting a pillow under the abdomen. So this is the position. Now this patient has got left side symptoms, so we are going to do a subpedicular or supraneural safe triangle approach of transforaminal epidural injection. So this is head end side, this is tail end side, this is right side, that's left side, and patient position is this way. So the intervention site is nicely scrubbed. Now it is scrubbed and draped. You can see the ergonomics. The patient has got left side symptoms, and we're going to do a pain intervention from left side. So the CM is also on the left side, and the monitor for viewing the fluoroscopy is also on the left side. This is the ergonomics. I am standing on the opposite side, so I should be exactly opposite to CM. Now your first fluoroscopic view is AP view. In order to know that the spinous process is equidistant from the pedicle. Now you could see the fluoroscopic image. They have taken first AP picture. See, if you look at here, this is a spinous process, and here comes the pedicles. The pedicles are not equidistant. Now you see here the distance is less, here the distance is more. So there is something abnormal. So you can adjust or make equidistant by tilting the fluoroscope either 5 to 10 degrees on either side, but your technician should remember every time. So that is never possible. That's why better tilt the table. Now we will tilt the tables. Now the table is tilted, we will take a AP shoot. AP shoot please. Now you see after tilting the table, if you see the distance between the pedicle and the spinous process is made equal. So our purpose is solved. But the second thing is we got to square this end plates. Now if you look at here, this end plate, this is L5, this is S1. Our target area is L5, S1 foramen. So if you look at the lower end plate of L5, it is as having two parallel lines. It's almost like an oval. So now we got to square this. How do we square? By just cephalad tilt of the CM. Now we will take a shoot after making CM cephalad tilt. Now you see, in order to square the end plates, we have tilted the CM little cephalad, almost 5 to 10 degrees, so that the end plates are squared. They are in plane with the X-ray beam. The anterior part of the lower end plate and posterior part of the lower end plate are in plane with the X-ray beam. That is the purpose. Now you see, the spinous process is equidistant, as well as this is L5 vertebral body. You see this is lower end plate. There is no double image. It is crispy clear. The lower end plate is crispy clear. It is completely squared. Now you see the fluoroscopy. Now we have put the fluoroscopic in oblique view. We have taken almost 30 degrees. There is no hard and fast. It should be 30. It could be 35. It could be 25. Already I told in my previous videos, we have to tilt it till the spinous process is pushed to the opposite SAP-IAP junction. So now we have put exactly 30 degrees for this patient. Let us see the fluoroscopic image. Now if you look at here, this is after 30 degrees of obliquity, a fluoroscopic image is obtained. This is left side, this is right side. If you see here beautifully, there is a Scottish dog appearance. Look at here, this is the Scottish dog appearance. This is a Scottish dog appearance. If you look at here, the nose of the Scottish dog is formed by the transverse process. The eye or the face of the pedicle, the face of the Scottish dog or eye of the Scottish dog is formed by the pedicle. The ear is formed by SAP, superior articular process. Front legs are formed by the IAP, inferior articular process. The neck, otherwise called as, the neck is formed by pars interarticularis. Sometimes there may be a lysis, that is called spondylolysis, wherein there is a break here. And the body of the Scottish dog is formed by the lamina. The spinous process is pushed opposite side. I already told you that is pushed along the SAP and IAP. Here the SAP, the Scottish dog's tail is formed by the SAP and hind legs are formed by IAP. So in oblique view, you should appreciate the Scottish dog appearance. And in my previous video, I told you how to do a 𝗚𝗡𝗏 or suprapedicular or infraneural approach. Today we are going to discuss about, this is a pedicle, we are doing under the pedicle. So this is subpedicular. Since the exiting nerve root will go like this, so it is a supraneural approach or safe triangle. Actually, it's a misnomer. It is a most unsafe triangle because there is a radicular artery which feeds into the artery of Armamentarium. So if there is any particulate steroid getting into this radicular artery, it can cause anterior spinal artery syndrome, which can lead to quadriplegia, anterior spinal artery syndrome, or even the needle hits the radicular artery, there could be a hematoma. That is a problem. But I don't know how the safe triangle has come. I say it's a misnomer. So you look at here, the two needles are placed. This is for transcameans, this is for subpedicular approach. Now we will give local infiltration and do the procedure. And the procedure is being done by Dr. 𝗣𝗜𝗏. She is pain interventionist at Panacea Spine Pain Ortho Sleep Center. So after attaining a oblique fluoroscopic image, the Scottish dog appearance, local anesthesia is being infiltrated with 1% xylocard. Xylocard is normally available in 2%, but it is made 1% by adding normal saline it is methyl paraben free, which is a preservative which can be allergenic to some of the patients. So we are using purely 𝗖𝗘𝗘𝗣. So if you look at here, being used as a radiological marker, and 1% lidocaine is injected, and the direction of injection should be along the fluoroscopic beam. Fluoroscopic beam is our eye, the fluoro is our eye. So if you look at here, after attaining the Scottish dog, our target area is below the pedicle. That's why it is called as subpedicular approach. So if you look at here, this is the pedicle. So exactly at 6 o'clock of the pedicle or 6:30, if you assume this as a clock, just assume as a clock, at 6 o'clock of the clock or 6:30 of the clock is the target area for subpedicular approach on the left side. If you are doing on the right side, it becomes 6 o'clock or 5:30 in the clock is the target area. So now we will insert a 22 gauge Quincke's needle from here. Now a 22 gauge Quincke's needle is inserted under fluoroscopic beam. Now if you see here, with the help of a 22 gauge Quincke's needle, exactly the target spot, at the target spot the Quincke's needle is inserted in a coaxial view. Coaxial view is nothing but end on view, wherein the tip and hub are exactly parallel to the X-ray beam. So we will check in the lateral view in order to know the depth. In order to know the depth of insertion, the fluoro is placed in lateral. Now you see, this is a lateral fluoroscopic image. This is the L5 vertebral body, and this is S1, this is intervertebral disc, and here comes the pedicle. This is subpedicular area. Look at the needle, exactly it is just placed into the upper part of the foramen. If you see, this is a foramen. You try to go through Campbell's approach, your needle will be somewhere here, but since this is placed in upper part of foramen, it is subpedicular approach, and your exiting nerve root will be going like this, and your traversing nerve root will be going like this, and exactly you are in the foramen. Now we will give 𝗖𝗘𝗘𝗣 dye, which is diluted in 30:70 ratio, wherein 30 is the dye, 70 is the normal saline. Initially we will inject only 0.2 to 0.3 cc of dye to check whether the dye has gone inside the disc, or whether it is in the epidural space, whether it is subdural space, whether it is intrathecal space, or whether it is in the artery or a vein. So you can use two modalities. One is a continuous real-time fluoro and inject the dye, or you can inject 0.2 to 0.3 cc, wait for 8 to 10 seconds and take an X-ray beam to see whether the dye is in the epidural space. An extension line with 𝗖𝗘𝗘𝗣𝗑 dye, initially we only inject 0.2 to 0.3 cc and check whether it is in the epidural space. Otherwise, if it is not in epidural space and you inject too much of dye, you cannot redo the procedure at the same level. So the philosophy is just inject 0.2 to 0.3 cc and see that it is in the epidural space. Then if you want to appreciate the structures, you can inject more, 1 to 2 ml, no issue. So you see the extension line. Now you see she has hardly injected 0.2 ml. You could see the spread of dye in the anterior epidural space, and the exiting nerve root is also stained in lateral. Now we will take epi view. Now you see the dye contrast image. This is the exiting. This is L5 vertebral body. This is L5 pedicle. Under the L5 pedicle you get a L5 exiting nerve root. Look at here, it is nicely stained. And in AP what you have to see is the needle should never go beyond the middle part of the pedicle. If your needle is breached the middle or medial part of the pedicle, it means that there is a probability that your needle can be in the intrathecal space. So always see to that. Tip of the needle, you see here, this is a needle which is stained nicely with the dye. It should never go cross beyond the middle or medial pedicular line. So you see nicely the exiting nerve root, the L5 nerve root is nicely stained. So that's why, as Dr. Deepa told, the indications for subpedicular approach is selective nerve root block, where the diagnosis is in ambiguity. Patient has got symptomatology, but MRI has got nothing to do with the symptomatology. But you want to find out exactly the pain generator, then you can give just 0.2 cc or 0.3 cc of lignocaine and ask the patient whether the patient's symptoms are relieved, so that you can put a diagnosis for the patient. That is number one. Number two, for example, all these pedicles are being screwed with the pedicle screws and a lot of hardware. It's a failed back syndrome and you have no options left over. Then if you want to do a DRG, pulsed RF, so you can place your RF needle somewhere here, exactly at the middle pedicular line or middle pedicular line, where you have the DRG somewhere here. You can do pulsed RF. There are the two main indications. The third indication is if there is a huge disc herniation. If you are doing through a Kamins approach, your needle can go into the disc. So that is the third most common indication. So now our needle is able to stay in the exiting nerve root. After double confirmation, the needle is in the epidural space. Now you see we are injecting normal saline 5 to 10 cc in order to flush away all the inflammatory mediators, the chemical mediators which are generated because of the disc herniation. The nucleus pulposus is a foreign body, it amounts to lot of inflammation. We are flushing away all the inflammatory mediators with the help of normal saline. It is being injected through a extension line. After giving normal saline flush, now we are injecting a 𝗣𝗜𝗜𝗡𝗘, any steroid, whether it is a particulate or non-particulate. Since we are doing below L3, at our institute, anything below L3 we give 𝗣𝗜𝗜𝗡𝗘, which is particulate. But if you are giving above L3, we try to avoid these particulate steroids in the form of methylprednisolone or triamcinolone or betamethasone. These particles are more than the size of RBCs, can occlude your radicular arteries, which can be feeding vessels to artery of 𝗦𝗣𝗜𝗡𝗘 and can cause anterior spinal artery syndrome, which leads to quadriparesis or quadriplegia. So now here, for each level, we inject 2 ml of steroid mixed with a long-acting local anesthetic in the form of ropivacaine or bupivacaine. If it is ropivacaine, it is 0.2%. If it is bupivacaine, it is 0.25%.
Needle, it should be subpedicular, just below the 6 o'clock position of the pedicle. It should not go beyond the middle pedicular line. And the spread of the dye, it should be hugging the pedicle. Here, as we can see, it is hugging the pedicle. The nerve root is nicely, it is the dye has spread through there. You can see even small epidural fat globules which are unstained, and you can even see the slightly stained on the opposite side. Even the opposite side nerve root is mildly stained. So this is a optimal image which you are supposed to get on the fluoroscopy at the end of the giving the dye. How the spread is, according to that we will reposition, or should we increase the depth, all that we will decide according to the dye spread. As a beginner, you might not be sure where the needle is. So if the needle is outside the pedicular, it is not even touching the mid pedicular line, it is somewhere outside, you might not see this kind of dye spread. You might be in the muzzle layer still. That means you are still dorsal, you have not entered the epidural space yet. Then you might get a muscular spread, the striations like that, the spread will be there, and that is not optimal. So that means that you have to still insert the needle more, the depth should be increased, then check in the lateral position if you are in the right depth, and then only give the dye again. That's why, as we have told again and again, initially just give only 0.2 to 0.3 ml of dye, so that your working field, you are able to see it better, so that it is not marred by the dye spread and you are not able to see anything. So only 0.2 to 0.3 initially you give. If you see a muscular spread of the dye, that means that your depth is not enough. So you have to push the needle slightly more, check again in lateral position if you are in the right place, and then only go ahead. If you are too lateral, and your depth is showing that it is already the deep enough, that means you're too lateral. Here it is, then what you have to do is that you have to reinsert the needle. Bring out the needle and reinsert it so that you are little more medial and you can get the correct positioning. Next, if the dye spread is just you are able to see the nerve, it is only the nerve is getting stained, you are not able to see the epidural fat globules, or it is not hugging the pedicle, it is not going above or below, the spread is not there. That means that it is still outside and it is just near the nerve root, it is near the nerve root, but it is not gone inside still. That means maybe it is touching the pedicle, but still you need to negotiate more, the depth should be increased more, go more medially. Next, if there is, it is gone into the dura, that is dural puncture has occurred. Reposition the needle, you should bring out the, first of all you should aspirate the dye and you should bring out and reposition the needle because it has punctured the dura and it has gone, it is not in the epidural space anymore. Then if you see a thecal, intrathecal kind of dye spread like this, then you have to abandon the procedure or you have to do it in another level. We are not supposed to give the drug or anything else if there is a intrathecal spread of dye. Then you are having in some vessel which is in the foramina. So in foramina has vessels, and if by mistake you are gone into the vessel, you might not always get an aspiration test, you might not always get a blood stain. So when you give the drug and there is the dye spread is similar to a vessel pattern, that vascular pattern which you can see here, then again you have to reposition the needle. You should never give the drug if there is a vascular pattern, especially if you are giving a particulate depot steroid. You should never give a steroid which is particulate, especially in the vascular, because the particulae are so large that it can block these vessels. So we don't want to have any kind of bad consequences of this procedure. So if you are a beginner, try to avoid particulate steroid, because both the type of steroids, the particulate, non-particulate, they will have similar kind of effects. So go with the non-particulate and always look for a vascular pattern and reconfirm that you are not in the vessel. Always after giving the drug, even if there is no vascular pattern, try to avoid accidental disc puncture. So keep the needle so that you are checking laterally every time before going to get. That means you are in the disc, and slightly bring out the needle, try again, check again, and then only give the drug. Don't give into the disc. And always try to avoid entering the disc. Keep checking in the lateral view so that you don't enter the disc, because by mistake, if how much ever aseptic precautions we have taken, we might cause some kind of discitis, and we want to avoid such complications. Last but not the least, if you go intraneural, that is the nerve, you are going into the nerve and you give the drug, that will cause something like this appearance, that is tram track appearance it will be. So you will be able to see the on either side of the nerve the dye will be spread. You might even be able to see the dorsal root ganglion. So that should be avoided at all costs, because it's very painful. As soon as patient complains of pain, as soon as the patient says that he is having radiating pain or shock like pain which is radiating to the leg, immediately stop. Don't give the drug, don't give the dye anymore, and please do not give the drug, because that can cause direct nerve damage. Thank you. And I hope you learned a lot from this video, and I hope you subscribe to our channel. Thank you.